Good morning, everybody. I'm going to say this a few times so everybody is aware. First of all, thank you for coming on this Wednesday, on a Saturday morning, Saturday morning. So, just to say that, we all know that the issue around sexuality and sex and vasectomy is a constant theme and something that, all the clients, or most men really are concerned about and are interested in. So, we are, that's why we thought it would be a good topic to discuss. And we're here to talk about that today. Before we do that, I do want to just really briefly just say a couple of things is that this year, as many of you know, World Vasectomy Day is taking place in Argentina. We have partners there at the Ministry of Health level at the province of Buenos Aires. Quite a few doctors are going to be visiting with us during the time, and some of you are online now, and we really appreciate that. It's going to be a very active week. So many things going on. This year it's in Uganda. Next year will be in this year it's in Argentina. Next year will be in Uganda. Last year we were in Zambia. So we tried to go sort of continent to continent, and we don't know after that, but that's already, start thinking 2026. But right now it's 2025. A lot of things are happening. We're really excited. The program has grown, the partnerships have grown, your guys' commitment has grown. I just wanted to talk about during the 24-hour event, and this is directed to everyone who's a doctor who's listening now. During the 24-hour event this year, for the first time, we're setting up a room within the Zoom environment where we do the live stream. There's going to be one room just for doctors to present cases, to visit your clinics, to talk about difficult cases, just to share. And we're looking for anywhere between 25 and 50 doctors who are willing to take 10 minutes, 15 minutes, time zone that matches your time zone, just so we can connect and make it, very focused on that. So it's really focused on your work that you're doing and to share it with other doctors. So it's something we've saw. You guys are, a lot of people have to talk. We don't always get a lot of contributors in terms of the webinars, but now's a chance for everybody to contribute and really just to see the conditions you're working and answer questions and just share story as we travel around the world. We'll be trying to start, as we always start, in New Zealand or in Australia, and then we kind of head west, eventually ending 24 hours later in the host country, which this year, as we said, is Argentina. Uh, all of this, and I never do this because I really hate doing it, but all of this does cost money. And we are fortunate that we have some really good, generous partners. DKT was amazing. They've been helping us out for years. And this year we have a big project we're doing in Africa, in Zambia, and in Uganda with the support of SIF. We've been supported in the past, and this year we're still supported by the Bergstrom Foundation. But at the end of the day, most of the support comes from individuals, and we really need that support. And I'm asking really from my heart, everybody works incredibly hard. We just need, we're going to come back to you about this. You don't, no big deal. But right now, we are going to put in the chat a link for donations. If you can, that would be great. But that's really, from your hearts. But we will be bugging you about the money thing just because it's really coming to that place where it would be really helpful. So that's put that aside now. I just really want to introduce Deidre. And Deidre is going to be, many of you know Deidre Smith. She's been with the organization pretty much since day one and is, a big part of what we do. This year, she's been doing a lot of things. She's going to be coordinating with myself and others the 24-hour event, but she's really worked very hard with a group of people. And I, would be remiss not to mention like Maria Rene Peronda, who's been really helpful, and Deidre and Michelle Lebrecq, and all of the speakers, of course. And I'm going to forget some people, and I know Silvana, and there's a lot of people that goes into this. Kati, of course, and Misule, who's based in Zambia now, in South Africa, but he's been doing the flyers. I just want to thank everybody. We ask a lot, we do a lot, we're energetic. And for those who read the newspaper, which I hope is all of us, or at least the news, the world is in fire. It's a crazy time right now, and a lot of programs of reproductive health around the world are being under attack. Mostly focused, of course, exclusively on women, and it's a chance for men really to step up. And for those who work in male-focused reproductive health, it's like it's not just enough to take the burden off of women's bodies. It's really time for us to like actually fight for some of the things that we hold so dearly, because just as I know for women it's a basic human right, it should be considered the same for men as well. So for that, I pass it on to Savannah. Savannah, sorry, Savannah. I pass the message mic on to Deidre, and Deidre, you take it from here.
All right, thanks, Jonathan. Welcome, everybody. I'm so glad to see everybody is here today. This is going to be an exciting discussion. It's going to be a very interesting discussion because we have questions from all over. We have so many questions. It's going to be great. And so my job really is just going to be, I want to introduce our moderator. She has the big job of introducing and talking to you all. But she is Rebecca Porter, and she is the managing director of Blue Kit Medical. It's a trusted provider of high-quality medical devices, and where she has been at the helm of strategic growth and expansion since 2015. We are so lucky to have her. She's coming to us from the UK. So welcome, Rebecca, and please take it from here. Your mic is off. Your mic. Kate. There we go.
Done. Fabulous. Thank you, Deidre. Welcome, everybody. It's fabulous to be here, and I thank Jonathan and Deidre for having me here with you. So yeah, let me share my presentation. Fabulous. Okay, so welcome everyone to today's webinar, VasectoSex, everything you wanted to know about sex after vasectomy, but were afraid to ask. This is the perfect forum for you to ask those questions. I understand today that we have more than 400 registrants already, so we have a wide-reaching audience, global audience.
You've got a little pop-up on. You might just want to take it off your screen.
Thank you. There we are. Fabulous. Thank you, Naomi. So across the world, the single greatest anxiety men express when considering, let's get this as well, when considering a vasectomy is whether it will harm their sex life. Fears about libido, erections, or ejaculation. These myths persist, and they often delay decision-making, meaning women continue to carry the greatest burden of responsibility for contraception. But we can change this by empowering men to make informed choices that work for them, their partners, and their families. Today, we're going to explore those fears openly and honestly. This is a frank, evidence-based conversation about what really happens to sex life after a vasectomy. Spoiler alert, most men and their partners find it actually gets better. So today's focus over the next hour will be listening to our wonderful medical experts, sexual and reproductive health specialists, and most importantly, real men and couples who will share their own pre-vasectomy worries and post-vasectomy experiences. Family planning isn't just about preventing pregnancy, it's about making space for joyful, worry-free sex. Here's how the session will flow. We'll start with Dr. Naomi Sutton, a medical expert who will tell us about what the science really says. Then we'll move on to the emotional and relational side of the decision. We'll listen to men and couples share their story. And then finally, we'll open the floor for your questions. Nothing is off limits. So an introduction for Naomi, Dr. Naomi Sutton. Naomi is our medical expert today and will be presenting for us. Dr. Naomi Sutton qualified in 2003, completing her MRCP in 2006. She went on to train in genitourinary medicine, gaining further accreditations in this speciality, including her diploma in genitourinary medicine and diploma in HIV, before taking up her consultant post at Rotherham Sexual Health Services in 2016 here in the UK. Naomi has developed a passion for psychosexual medicine, becoming a fellow of the European Society of Sexual Medicine and recently training as a fabulous vasectomy surgeon. So over to you, Naomi.
So yeah, thank you, Rebecca, for that intro. Just to say, I think just to explain what genitourinary medicine is, because it's not a speciality outside of the UK or Australia. My job basically focuses on sexually transmitted infections, including HIV and contraception. So it's quite a specialised area, and that's how I've come to train to be a vasectomist. But I've been in this field for nearly 20 years. I am very new to vasectomy. My trainer's on. Thank you, Melanie, for joining me. But yeah, my interest, I suppose, in psychosexual medicine. So I'm going to cover briefly what sexual problems are. And when I'm referring to men or males, I'm referring to those assigned male at birth, including trans women. I'm going to briefly outline what I mean by sexual problems, what we know about them in relation to vasectomy, and how we can go about discussing sexual problems as a healthcare professional so we can make some sort of management plan, whatever our level of knowledge is. I appreciate we're coming from all different backgrounds, but this is why sharing knowledge is so important. I definitely don't have all the answers. I don't claim to. So I hope I learn from our esteemed panel along with everybody else. So yeah, so first we need to consider how we define a problem can be anything which involves the person's concern in sexual functioning. So when we're thinking about sex, this can involve any part of the sexual event. So that's desire, arousal, orgasm, or pain during sex. Pain as a sexual problem is much less common for heterosexual men, but a much more common sexual problem for women. Can we go on to slide 2? Thank you. So to be defined as a sexual dysfunction via the International Classification of Diseases, or the DSM, the problem must cause a clinically significant disturbance in a person's ability to respond sexually or to experience any sexual pleasure, resulting in a lack of satisfaction. So what I don't want to do is confuse problems, which can be sorted out quite quickly, and then a sexual dysfunction. So we're kind of talking about two different things. The dysfunction, to be a dysfunction, it also needs to be causing significant distress to the person who's experiencing it, and so it's reducing their quality of life and persist for several months. So if we move on to slide 3. So again, going back to sexual problems, that incorporates any problem or a dysfunction. How common are they? So I think it's really important to understand that concerns about sex are a normal part of the human experience and not dysfunctions. So the problem might be transient or not cause significant distress, for example. And problems often stem from a lack of knowledge or false beliefs based upon prevalent socio-cultural norms and sexual scripts. So, for example, throughout time, the penis has been seen as a symbol of masculinity, worth, virility. So if there's a perceived problem, the man may see himself as less worthy of love, etc. It might affect his self-esteem. And when I'm talking about sexual scripts, I'm talking about how culturally we may perceive sex, especially we're talking about heterosexual or heteronormative populations, if someone's having a vasectomy. And sex is often focused on a penile vaginal penetration. So there's a lot of pressure on the man to be able to perform this function. And interestingly, less than 20% of females will actually orgasm from this type of stimulation. Most women need direct clitoral stimulation, yet the script persists within heteronormative populations. And there is an orgasm gap which remains between the sexes, but that's probably a talk for another day. But a lot of sexual problems can be resolved with reassurance, education, behavioural advice, and positive experiences moving forwards. So, for example, there's a lot of myths about how big a penis should be or how long sex should carry on for. So the average penis size is 5 to 6 inches, obviously depending culturally where you live. And the average penile vaginal penetration time is about 6 to 10 minutes. And both of these factors are often overinflated in situations that people might be viewing online, for example, porn, etc. So when we look at the most common sexual problems people may present with, they are erectile dysfunction. It's estimated that about half of all men between the ages of 40 to 60 will have erectile dysfunction to some degree. Premature ejaculations, this is when a man ejaculates sooner than desired during sex. Medically, we define that as less than 1 minute of penetrative sex or intravaginal ejaculation latency. So that's how IELT, that's how we would quantify it. And the estimated prevalence of this is about 30%. In 30% of men at some point in their lives will struggle with premature ejaculation. This will actually decrease with age as a sexual problem because the sensitivity of the penis decreases and control over ejaculation might increase. But again, this will be event specific and depends on stimulation factors. There are lots of other problems that can happen with ejaculation. So anejaculation, when there's a complete absence of ejaculation, that can happen with or without orgasm. Various causes, including nerve damage, medications, psychological factors. You can have retrograde ejaculation, common in diabetes mellitus, the bladder neck muscle fails to close. So at orgasm, the sperm enters the bladder. You can get anorgasmia, so you can't orgasm, but you may still ejaculate, delayed ejaculation, hypospermia. Sometimes your vas deferens doesn't form properly, or cystic fibrosis might affect that. Ejaculate volume, which we're going to talk about a little bit, but that does decrease with age. Other causes which might affect volume are medications, alcohol, dehydration, psychological stress. And we're going to talk about the vasectomy effects. And then decreased desire, this can affect up to 1 in 5 men at some point in their lives. Likelihood of this does increase with age. So we've got to consider whether there's an underlying medical reason, so reduction in testosterone levels, but often it can be relationship problems or a combination of lifestyle and other medical factors. So stress, poor sleep, poor diet, diabetes, obesity, antidepressants, and also other sexual problems will then potentially reduce your desire to move on and have sex. Can we go on to the next slide? So I hope most of you will have heard of the biopsychosocial model. So this is a framework which incorporates all the different factors we need to consider when faced with sexual problems, and there will always be an overlap. So if someone does present with a sexual problem, we need to consider and ask about all the biological causes, which as medics, I think we're quite good at. So we need to take a full history, including cardiovascular risk factors, diabetes history, medications, opiates, etc. But we also need to consider the biological, the psychological, the behavioural and the societal correlated factors. If there is a problem post-vasectomy, we need to explore his feelings around this. So does the man trust the vasectomy? Is he still concerned about pregnancy? What's happening at home? It could be nothing to do with the vasectomy, but something which was happening before he had the procedure, or it would have happened anyway. And then we need to consider sexual attitude. So, you know, is it something about him feeling less manly? Has that affected his perception of himself? So his feelings, his beliefs, his gender identity, cultural definitions of masculinity and femininity. And also consider not only the client, but the couple. So does she have sexual problems which are then affecting his sexual drive or etc.? Can we move on to the next slide? So this is just some diagram. This is basically the physiology of an erection. And we were designed to be able to override our sexual responses because this was useful if we were frightened or anxious. If, for example, if a tiger was outside our cave, we would not want to be having a lovely, pleasurable sexual experience. We'd want to be able to reduce our erection and run away. But there's less risk of tigers now, but stress and anxiety from other sources will still have the same effects. So the physiology of an erection is very complex, but it starts with sexual stimulation, which can be anything really, but maybe sensory information for the genitals or psychological factors. That results in a neural activation signal to the brain and spinal cord. This in turn activates the parasympathetic nervous system, which is responsible for the pro-erectile responses. So this in turn then activates triggers the chemical and vascular changes with nitrous oxide release and other vasodilators such as VIP, vasoactive intestinal peptide. This causes smooth muscle relaxation in the arteries and the erectile tissue. Then that results in blood flow and engorgement as the penile arteries dilate. Because of the hardness, they occlude. The venous occlusion happens, which maintains rigidity, and the maintenance of the erection is continued via continued release of nitrous oxide until triggered by the nervous system, normally through orgasm or ejaculation, which then allows the smooth muscles to contract, blood flow drains away, and that's generally the end of
You've just put
Naomi, you got
yourself on.
muted.
Naomi, you are muted.
Oh, how long have I been mute for?
20 seconds.
Oh, 20 seconds. Okay, so I was going through the physiology of the erection, but so you can see from the second picture that anything stressful is going to increase your sympathetic tone, not allow your parasympathetic tone to get the erection off the ground. So again, you don't have to explain all those different pathways to a man, but by explaining that stress and anxiety are going to stop the erection happening, that can often help. Can we move to the next slide? So when we're looking specifically at vasectomies, it's really important that we address expectations, concerns, and anxieties, which Rebecca sort of touched on before we operate and perform a vasectomy, especially as we know that stress is a buzzkill, and often education about genitals and sexual functioning process is often very poor. So this is a very recent study published in Sexual Medicine from December 24, and it looks at online forums to explore men's experiences with vasectomies. And it's evidence to show that men utilize online platforms to cope with their pre-op anxieties. They seek validation, they want to share experiences, and the common concerns around pain, ejaculate volume, and erectile dysfunction. And there was a notable discrepancy between expectations set by healthcare professionals and the actual post-op experiences shared by patients. So it's really, really important that we understand the concerns and address them at pre-op counselling. So we need to preempt these thoughts and feelings before they happen. Can we move to the next slide? So does a vasectomy cause sexual problems? So if we think about what we're actually doing during the procedure and think about if there's any biological cause why it can happen, there isn't. So that's what we need to discuss at pre-op. So men often have, well, everybody has very funny ideas about how their genitals work. So it doesn't change hormone levels. There might be a lack of understanding of the anatomy, and men might feel that if you're cutting the tube to the testosterone, if we're cutting the tube to the testicles, we know it's not delivered via the vas, but men might not know that. The procedure doesn't impact blood vessels or nerves responsible for erections, and in the little picture I've detailed all the contents of ejaculate. So very, very little comes from sperm itself. So it's unlikely to produce any noticeable reduction in ejaculate volume because we're only removing the sperm content, so 1 to 5% of the ejaculate. The rest gets produced upstream, as is illustrated in the diagram. And it's also I've said as well that there's lots of other things that can reduce ejaculate volume much more likely than a vasectomy. And pain, I suppose, is always going to be a bit of an issue, because if something's hurt, you're then not going to want to potentially have sex. But pain post-procedure is definitely a possible cause of sexual problems. But longer term, it is very rare. And there's data from the UK showing less than 2 in 1,000 will struggle with chronic testicular pain syndrome. So it's much rarer than is quoted in other places. Can we move to the next one? Can we just move the slide on? Thank you. So this is another paper from Sexual Medicine in May of this year showing that on average 8 years after undergoing vasectomy, men don't experience differences in selected dimensions of sexual self-concept. And I think that's really important that it's their self-concept. So that's things such as toughness, body image, sexual self-esteem, and perceived pressure regarding sexual performance compared to men without a vasectomy. So these things are all relevant for everybody, but post-vasectomy, it doesn't make a difference. So this is important because it can alleviate concerns about men considering a vasectomy, about the potential negative impacts on their sex life. Can we move to the next one? So this is my last slide. So I think it's just important to consider how we approach a patient with a sexual difficulty in any situation. It can be very stressful for a healthcare professional if you don't have any kind of framework or knowledge in this area. But if we don't start somewhere, we're never going to learn. So we all know how to take a history. We've got to take a detailed history, including what the problem is. That's timing, the type of problem, the associated symptoms. Like anything else in medicine, we often have blockers ourselves, not knowing quite how to phrase the question. And if this is the case, we do need to look at our own stigma and shame and what we're bringing into the room. Did it arise suddenly or gradually? In what context does it arrive? So is it a partnered problem or is it a partnered and a solo problem? And when I was doing my VasectoSex thing, one of our educators said, be voyeuristic. So try and get a video of what's going on in their bedroom, which sounds a bit weird, but then you can kind of understand the stepwise of what's happening just to get a really good understanding of the situation the person's describing. You need to probe so you can try and work out where in the sexual cycle the problem's occurring. So is it a desire issue? Is it an erection issue? Is it an ejaculation issue? Is it an orgasm issue? And medical history is obviously very important. So we need to look at cardiovascular disease, metabolic syndrome, diabetes, etc. Are there on any new medications, especially antihypertensives, recreational drugs, marijuana, opiates, cocaine? Are there any life stressors? And after going through all these sorts of things, we should have an idea of whether this is predominantly a medical or a psychosocial problem. And again, ensure when you're asking the questions, be open-minded, empathetic, and not judgmental. And remember to treat the person, not just the penis. So in medicine, we like to compartmentalize areas into endocrine, cardiology, urology, but the person will have overlapping problems. So it must always be patient-focused. We can always give basic information, incorporate prevention, health promotion. So stopping smoking, exercise, weight management, and again, really important not to over-medicalize sex because that might cause further distress and anxiety. So as a healthcare professional, you don't always need to do anything. Sometimes just education, letting someone talk might be just what they need. We do like to give somebody something like a tablet to take away, but that's not always the best management plan. Remember, as a healthcare professional, you've got a lot of power to educate, and people do listen to us and take our advice. So they may just need some advice about, I guess, how they see themselves, etc., and diet, lifestyle. So depending on your level of expertise, you can either instigate management or refer on to a specialist, and this will depend on the problem. And don't forget sex therapists and other psychological inputs, because often people may need both. And then ultimately the aim of sex is sexual satisfaction. We know it's a quality of life indicator and it's important to preserve, but what does that mean to the patient? So it doesn't mean we have to be having the same sex that we had in our late teens to still have sexual satisfaction. So I think it's really important that we keep that perspective in our mind, and not be a little bit more realistic if someone does have a sexual problem. Final slide is just saying any questions, and then I'm going to hand it over to my esteemed colleagues.
It looks, well, thank you, Naomi. That was fantastic. It looks like Dr. Ramiro Fregas might have a question, but it's in Spanish, so I won't be able to interpret that. I wonder if
Yes, so I just
Ramiro
wanted
would like
to
to
share one particular
speak.
experience regarding sexuality and Down syndrome. So children that are in a school where they have a lot of children with Down syndrome, and sexuality is quite heightened when it comes to people who have sexual syndrome, Down syndrome. And a lot of times, parents come to me to ask for a vasectomy for kids, for teenagers, for example, that have Down syndrome. So that's my question. What would you do? And for example, can a vasectomy take care of premature ejaculation? Also, can it help women that can't have an orgasm? Does vasectomy erase all the barriers when it comes to getting pregnant? So is vasectomy always good for people that have erectile dysfunction? Also, is there a risk for people, especially for women who have diabetes or heart diseases? And also, imagine in a couple, they already have had a child, and the woman has an illness and they want to have a vasectomy. So is this good in order to avoid a higher risk for the female?
I wouldn't mind taking a stab at answering some of those. Is that okay?
Go for it, because I didn't understand what was said.
Oh, okay. There was lots of different things in there. Questions about what I understood is questions about like some stuff about who is eligible for a vasectomy, but in the setting of heightened sexuality or sexuality and ability to and questions of capacity and ability to make decisions about procedures and that types of stuff. And then I also heard Dr. Fragas a lot in there about what to tell people about effects if they have pre-existing sexual functions or pre-existing conditions and not. And one of the things, just as a family planning specialist, primary care provider, just person, is we're always very clear that with some rare exceptions of like absolute contraindications, that people's need for good birth control or for contraception can generally be considered separately from some of their other medical issues. So even with people who have like bloodborne diseases or other things like that we might be concerned about and might be related to people's sexuality, we do, like, as people who are doing family planning and are people who are helping people make decisions and have access to birth control and contraception, that it is our primary focus if people are coming to us to talk about contraception, to give them what they need in terms of preventing pregnancy or avoiding pregnancy. So I think all of those questions that you said are important to take into consideration, but I think providing vasectomies for people or contraception can often be taken separately. Does somebody need birth control and do they want permanent contraception? Then they're probably, and can they understand what they're choosing? Then they're probably candidates for vasectomy, even if they have all of those things that you mentioned. So if anyone else wants to address the specific things, but that's how I would answer those questions.
Thank you. Sorry, I'm struggling to find where I get the translation from. I apologize.
Thank you, Sarah. There was originally 3 dots on the More section at the bottom of your screen, and you could choose interpretation next to a globe, which would allow you to choose the language. But I can't see that option now. I'm not sure if anyone else can contribute to tell Naomi how to listen to the interpreter.
Go to the 3 dots.
I
And
have
then the interpretation room will come up. If you don't see it automatically at the bottom.
I can translate the questions if you want.
Well, should we go with some in the chat that I can read?
Yeah,
Um,
sure. I think Alex Galante wanted to ask a question first. So can we take Alex, please?
Hi, can you guys hear me?
Yes.
Okay. And is there a lot of noise in the background? Because I can get in a more quiet space. I'm kind of in a car right now, but um, I'm glad this seminar is happening right now because it is actually perfectly timed with an issue that I've never experienced with a patient, well, a patient's issue, who actually I talked to on the phone yesterday, and I was hoping that I could share the story of the patient and maybe get some insights from the panel and from anyone that might have experienced something with a patient after a vasectomy. And so the story goes, and I'll try to be reasonably brief, and I'm happy to clarify any details if anyone wants more details. But this is a 42-year-old man who had a vasectomy in February of this past year, so it's about 7 months ago. And his post-op course was unremarkable. He did fine. He didn't have any issues with pain. His chief complaint now, 7 months later, he's reached out to me, is that his sensation of pleasure from his orgasm has reduced at least 50%. And this is something that happened for the first time he ejaculated after the vasectomy, so about a week after the procedure, and has been persistent and consistent for 7 months, without any change for the better. And he just reached out to me because he said, I wanted to give it a lot of time. I wanted to make sure this was just, not something that was just, kind of random. And so now he's had 7 months of this issue, and it's, substantially affecting his quality of life. He, of note, has no significant medical history, doesn't take any medications, hasn't started any new medications, has no history of drug use, or at least he denies any illicit substance use. He denies any new psychological stressors, denies any depression or feelings of anxiety. He works at an HVAC, and he's been doing that for 15 years. His job hasn't changed recently. There's no recent changes at his workplace. He's been in a stable relationship with the same partner for many years, and at least he denies any changes in the relationship. And she was on the phone call as well yesterday, and they both are just very concerned about this. And he just cannot identify any other factors that might have changed between literally the day before the vasectomy, when he felt like he was a 10 out of 10, and now he's a 5 out of 10. And the detail that he describes, the thing that he really feels like he's lacking, is that he used to get this pleasurable sensation in his scrotum and his abdomen, which he no longer feels. And he feels, so now he's just at about a 5 out of 10. And in looking at the literature, I've just been reading paper after paper about this now over the last 24 hours in kind of preparation of just my next follow-up appointment I'm going to see him for a physical exam next week. And, I'm trying to find literature that's, obviously going to reassure him and say, this is not kind of this is not typical. This is not expected. But one thing that's kind of a red flag for me is that you look at all these studies and they say, hey, listen, there's no changes. There's no sexual changes after vasectomy. Okay, there's these like 3 guys that had this issue, but okay, there's these 3 guys that got better. But I'm really concerned about those 3 guys out of the 400, or the 100 that had an issue. Now, the more I think about it, that's like, 3% of guys, 5% of guys, 1% of guys that are having these sexual issues after the vasectomy. That's a pretty high percentage. And I just wanted to get your thoughts on both what your thoughts are for this specific patient, and then if anyone has thoughts about the literature about these sexual issues, maybe being a little bit underplayed in the literature, and maybe a little bit what your thoughts are about that.
Thank you, Alex. Naomi, I'll give this to you, and then I'll do a brief introduction to Dr. Sarah Miller and Dr. Romero Fraga, and then we'll continue with the questions because it looks like there's a lot of questions coming already. So over to you, Naomi.
So Alex, this sounds like a really difficult one. I don't know if Sarah has any other thing, but I'd be interested to know if it was when he masturbates as well as has sex, or whether it's something relationship, because if it happened immediately after his vasectomy, it just makes me think, is there something going on in his head? So I would still want to investigate that virus. And also I'd question, what is it, what does he want out of the management, if that makes sense? So what can, because, and ultimately, if we can't find a reason, because we can't in medicine, a lot of the time we are left with, we don't know, but how we can help this man get through what he's experiencing to make it better. So if he can still orgasm and he can still have some pleasure, it's a case of sort of, I guess, reassuring that everything's still working. And I know it's not perfect, but sometimes it's like, you know, people have limbs cut off and all sorts of things happen. I would definitely question that it was anything that was specific to the procedure itself, because it, as I said, unless you've, you know, severed some nerves down there, it just feels unlikely. So I'd question whether there's something going on in his head. I don't know, Sarah, if you want to add to that.
Yeah, I was going to bring up a very similar case and of a patient who had a very similar thing. But one of the things that I just want to let, like, experiences I've had with birth control in general, is we really like to blame it for anything that goes wrong. And like, you get an IUD put in or a vasectomy and you walk out and get hit by a bus, like, are you going to say that getting hit by a bus is a side effect of a vasectomy? So, but with this patient, or a patient that I had that it was very similar concerns, and then he timed all his changes that were very similar to yours to the time of the vasectomy and came back. And I can talk a little bit about my approach, which I think is similar to Naomi, your presentation, and Alex, what you've already done. But then when I was speaking to him about how he communicated with his partner about it, he was like, well, we do communicate about sexual stuff, but we haven't really had a chance. I think it's because the baby is still so young. And I had forgotten when he came in for his vasectomy that he had a newborn, and this couple had originally not wanted to have children, and then they did, and then he came in for his vasectomy. So all of his issues, and some of them, like, he was having some pain, he was having decreased libido, he was having what he described in, like your patient Alex, in very specific ways, changes to the feeling of orgasm and amount and what came out. But also he had had a baby like almost immediately before he had a vasectomy. And so what I want to say with these things is whether or not, like, we should be reassuring as possible for the patients. Like, go over the stuff in their level of literacy and understanding, and show them how, like, physiologically, procedure-wise, pictures of nerves, all of that stuff, vasectomies really shouldn't do anything that changes this from, like, a procedure anatomical, physiological way. Try to be as reassuring as that as possible. At the same time, you don't want to tell them you're wrong and what you think is going on is not what's going on, because really what is going on is he's concerned and preoccupied and he's having a hard time. So we need to, like, try to reassure him as much as possible. We need to know that our patients, our bodies, we do not read the literature or the textbooks. So even if 99.9% of people, this is true, like, give some space for maybe your body is behaving differently to this. But everything that you said in your presentation, Naomi, about how our worries about it alone affects our sexual function, our communication about it alone does that. So aside from all the things that you're doing, treat underlying pain, reassure, bring them in, do a full exam. Good news, everything that I found when I examined you feels totally good and totally normal. Like, we did your post-vasectomy semen analysis, it's all clear. The procedure worked. The procedure did what it was supposed to do. Like, try to frame it all in a positive light. And if that is not working, then I would probably go to the same way that we treat sexual dysfunction for people who have not had vasectomies, meaning, let's make sex pleasurable. Let's take the pressure off of having to ejaculate. Let's do all of these other things that you can go into, like, treatments for sexual issues separate from the vasectomy.
Thank you, Sarah. Thank you, Naomi. Hopefully that helped, Alex. Deidre, you've asked me to go to Philippe next. Shall we do that? I would also like to do a formal introduction to the panel. Shall we do the formal introduction? Okay, fantastic. I know there's a lot of questions in the chat, so please bear with us and we will definitely get to you. So for now, let me just do our little formal introduction. So if I move. So as well as Naomi, joining Naomi, we have Dr. Sarah Miller. Thank you, Sarah, already for your wonderful contribution. Dr. Sarah Miller is a family physician and family planning specialist with over a decade of experience providing services in New York and Massachusetts. Traveling far and wide with No Scalpel Vasectomy International, Sarah serves on the medical advisory board of World Vasectomy Day and founded Northeast Vasectomy and Family Planning to promote family planning services for men and trans women. We also have with us Dr. Romero Fraga. I hope I've said that correctly, Romero. Romero is a specialist in urology and a member of the Cuban Society of Urology, Cuban Society of Sexology, Spanish Association of Andrology, American Urological Confederation, and American Urological Association. Most importantly, we're also honored to be joined by Pareja de El Salvador, representing couples from Zambia and El Salvador. Our audience today spans continents, cultures, and religions and ages. Most of you are medical professionals or students curious about how best to support men through counselling and care. These conversations are often not part of formal medical training, so today is a chance to learn together. I wonder if we will have Pareja speak with us today. Is that right, Deidre?
Hi. Yeah, yes, we're going to have questions in Spanish and English. So Ramiro will be speaking to those as well.
Okay, fantastic. So as you know, this is all about questions. Nothing is off limits. We welcome all questions. So let's jump straight in because I know we already have many questions. But first, Deidre, apologies. Philippe, you asked to go next. So Philippe, welcome to the stage.
Hello, can you hear me?
We can indeed.
Yeah, okay. So my question is the following. It's maybe a bit weird or off what we've been discussing, but I've had a vasectomy 2 years ago. And my current intimate partner, she says that during oral sex, so in general, during oral sex, she does not like the taste of ejaculate. But she told me that mine is much less revoltive than that of other men that she had tasted. And she thinks this is because of the vasectomy. So she says your vasectomized sperm is much more palatable, so to say, than that of other men. And I'm just curious because to me, I couldn't really believe that this has any effect on the taste. Yeah, I just wanted to ask if you have any, if you can, I think maybe it's just her idea that it's because of the vasectomy, but I don't know. So I just wanted to ask if it has a changing effect in taste of the sperm, the ejaculate. Thank you.
I'm sure Sarah will agree. So ejaculate changes mainly due to diet, as far as I understand it, rather than it being the content of the sperm. So it might just be that you're eating all the right things to make your sperm taste delicious.
Okay, thank you.
So yeah, some people say eating lots of pineapple makes it sweeter. I mean, I'm not sure, Sarah. I don't know if there's any studies or medical.
No, if I may add, I talked about this to another friend who said that because I'm vegan for several years, and a female friend of mine said that her experience.
Philippe, you've just muted yourself. Can I ask all the
I
other?
I was muted.
Okay. I just for all the other attendees, please just keep yourselves on mute if you've got background noise, so that's not interrupting. Philippe, sorry, continue or
Yeah, just to follow up. So because I talked to another female friend and she said that she thinks it's related to my vegan diet because she said she has experiences that like the ejaculate of that's what she said. I find it weird too. Of vegans tastes better than of non-vegans. But if I understand it correctly, that's at least more likely than the vasectomy having an effect.
I can feel a study coming on. Maybe you should run this one. A taste test of vegans versus meat eaters.
Gerald, would you mind muting? Thank you. Sarah, would you like to contribute to that?
I mean, I totally agree. I think it's much more likely that given the amount and how much is added by the sperm and what gets blocked during the vasectomy, that other factors contribute. But part of me thinks like, give credit to whatever, when we don't know and it's more likely something else, feel free to give credit to whatever you feel like giving credit to. If you want to like promote your veganism or your vasectomy or all of that stuff for your delicious taste, great.
What a great question. Thank you, Philippe. So
I do think, sorry, just for 1 second, that kind of thing though is something that like if you're hearing those things a lot from people, like might be part of your pre-op counseling for people who want to talk about sexual stuff or are worried about it ahead of time, like adding to like you shouldn't know there are no changes in hormone levels, no changes in blood flow, no changes in taste, or generally no perceivable changes in taste. That might be something if that's important to you or the population that you're working with.
Thanks, Sarah. So next, I think we have Emmanuel. Emmanuel, you're quite welcome to ask your question, but I can see here in the chat, coordinator of medical students from the University of Rwanda. Emmanuel's question is, how would you counsel a patient who reports chronic testicular pain or reduced sexual satisfaction after vasectomy, despite normal semen analysis? Would someone like to take that? Actually, Emmanuel's got a secondary question as well, which is some men fear vasectomy will affect their masculinity or sexual performance. How should healthcare providers address these misconceptions during counselling? Sarah, would you like to take that?
Sure. I find it helpful. I don't know if we want to bring up a diagram of the pelvic anatomy again, because for questions about, I mean, I think if somebody is having pain or pain issues related to the vasectomy or in their scrotum in any way, like we need to address that. Like that needs to be addressed as like urgently, like as part of, because pain in itself affects sexual function and sexual pleasure. For better, for worse. I don't want to yuck anyone's yum, but that's something with that. So if somebody's having pain, like especially if it's like immediate or early post-op pain, I will often advise like take some extra time and proceed back slowly to make sure that you're not connecting new pain and worrisome pain with sexual activity, because then that does all kinds of things of like laying down worries and concerns and patterns that you don't want to be laying down in terms of your sexual function and your relationships with people. What was the other question in there about changes in?
So
I can't see that. I'm having trouble.
It was about. Sorry, go on, Naomi.
Masculinity, I mean, studies have shown that men who have vasectomies have more sex on average. So I think, and like the joke we make and the truth is like, it takes balls to get a vasectomy. So as much as you can like let people know that doing it is actually like a really strong, like masculine, like a thing to do, that's meant to make your sex, like people don't have vasectomies to have vasectomies. People get vasectomies so that they can have sex for the rest of their lives without worrying about it. So the whole point of it is to be able to have a better, more pleasurable, worry-free sex life. So if you can just frame it that way for people, and then you can show them, if you want me to share a screen, I can show them like addressing issues about like, will I have decreased hormone level or decreased testosterone? Will I have issues with erections? Will I be, will anything come out when I ejaculate? Like, I think it's really important to show them the images of the male anatomy and go back to basic anatomy lessons or stuff even more about where the nerves are, where the blood flow comes from, where that the testicles make the hormones. When we're blocking the vas deferens, as far as we know, the only role of this tube, this vas deferens, is to transport the sperm into the semen. So we're not changing any of the other pathways and anything else that affects those levels of hormones in people.
Thank you, Sarah. Naomi, Sarah, you're welcome to share your screen if you want to pop up the image of the anatomy, if that helps whilst we're discussing. I will move on to a question from Jean-Claude. Jean-Claude, again, you're welcome to ask or join in the conversation, but you've popped in the chat you'd like to ask. There are some men and even their wives who have shown that after vasectomy, their feeling toward doing sex have been strongly reduced. Is it really the case of procedure, or is there another reason causing this problem?
Again, I'm sure Sarah will agree. Again, it comes down to this psychological concept of what the vasectomy's done to you as a man. So I think that's why it's really important we discuss all this before they go into the procedure and make sure it's right for both of them as a couple. You know, that there is no biological reason other than pain which may affect your sexual functioning. So if there is a sexual problem, it has to stem from either social, cultural feelings or social messaging that we're getting about you are now a Jaffa post vasectomy, or all these silly jokes that go around. So yeah, Sarah, I don't know if you want to add.
One thing that I do think is important in terms of that relationship part of it, because what I'm hearing in that one is about the relationship, is that I've been thinking about this a lot more in terms that having a vasectomy is a life transition for people and for relationships in couples. And I've sort of likened it to like a more fun, like people who go into hospice care or birth or other things, like helping people in transition periods of their life, that closing the door on procreation can be a significant time in people's lives. We see this with women going through menopause as well. It's a huge transition, and it's a huge time of sexual change and relationship changes. But that, even for people who are like definitively not wanting children or more children, losing that potential can be changing in relationships. And I've had conversations with patients who are very articulate about this type of stuff, that is hard for them. Either sometimes it's the partner that it's hard from, sometimes it's for their relationship dynamic, but that a significant part of their relationship up until then has been based on their sexual relationship in regarding either preventing pregnancy or trying to be pregnant or having children together. For many people, this has actually been studied in literature, the ability to conceive is an actual erotic thing. So there's like the part of our brain that like makes like informed decisions about like whether or not we should have kids or whether or not this is the right person to be with. And then there's the part of our brain that's like, I want to have sex with this person and I want it to be great. And this is like pleasurable. And they're not necessarily the same. So even if we know we don't want any more kids and we've discussed this and we have it, there's this thing that happens during intimacy or with people where like sometimes that potential is like incredibly erotic. So I'd also make space, that's kind of hard to have those discussions with people sometimes, depending on how you talk to people, but making space for like, there can be changes, but this can also be a transition, and keep having those discussions. And another aside, something I wanted to bring up is like many people don't know how to talk about sex in general and aren't comfortable talking about sex. Like some people did fellowships or went into specialties specifically to learn how to talk about sex, or like grew up with mothers who did sex ed or nurses who did sex ed. Like many of us have languages of talking about, but a lot of people don't. And part of what we can do as clinicians or med students or educators or sexual ed, whoever people are here, is to model having comfortable conversations about sex and to give people the language to be able to do that with their own bodies and with their partners.
Fantastic insight. Thank you, Sarah. Really, really interesting stuff. There's some, I can see that there's some great vasectomy surgeons who've joined us today. So if any of those want to also offer some insight, please do. We have another question from Liz Marie Miranda. Liz asks, how can we empower men to choose vasectomy as a family planning option if they want to have a family, but not at the actual moment? I ask this because people tend to think that vasectomies are permanent, so they don't choose vasectomy as an option because of future possibilities. So I suppose this question is about the permanency of vasectomy. Sarah, Naomi, or Romero, if you'd like to take that.
Definitely from my perspective in the UK, we would sell it as a permanent, irreversible procedure on the NHS. So we wouldn't pay. So it wouldn't be something, if someone was considering children, we would definitely consider other options. It's definitely for people who have completed the family from my perspective. I know you can reverse vasectomies, but that will depend on the healthcare system that you work within, because you'll end up paying a fortune and it's not always reversible. But I don't know if, I'm not sure where that question was from, which country.
I'm not sure either. Liz, please feel free to pop in the chat where you're asking your question from. Sarah, from the perspective of the States, is that the same advice?
Yeah, I might even defer that to the people here who do reversals, but in general, we're not trying to encourage it for people who want to have children in the future. I've had some exceptions to that, like people who come in and they've already stored sperm and they say, I will have the means to adopt if that doesn't work, or I know it will be expensive and I will be doing IVF when and if I'm ready in the future. Sure. But in general, we're not encouraging it for people who want families in the future.
Thank you, Sarah. I can see Deidre in the chat has reinforced the same message about choosing vasectomy, knowing it's permanent. Okay, so another question from Omar. Omar says, I would like to know if there is impotence after a vasectomy. Who wants to take that?
May I chime in? May I chime in? I don't see the raise hand option in the bottom, so I just turned on my thing. But I think that this could open up the topic of informed consent. And I have found it very useful. I think I've contributed this to the Vasectomy Network a couple of times, so I don't mean to repeat myself. But I started doing vasectomies only starting in 2000, and I was troubled by how to handle some of these questions. So in 2006 and again in 2010, we sent out postal questionnaires to 100 people in 400 people in 2006 and 2010 again. We got about 100 results. And the questionnaires were specifically this: how has your vasectomy, and these were to men who had had their vasectomies for at least 6 months, how has your vasectomy affected libido, rigidity of erections, quality of erections otherwise, sense of orgasm, etc.? All the questions that we have been doing. And the options for the men were much worse, slightly worse, no change, slightly better, much better. And we compiled all this information and actually put it on the website. And now it's even part of our informed consent. And the gist of the matter is that about 85% of men in all of those parameters said no change. Some of them said worse, slightly worse or much worse. Some of them said better or much better. And the numbers who said better outnumbered the ones who said worse. So the vast majority were no change. But when there was a change, the likelihood that there was a positive change, increased libido, better erections even, quality of the orgasm sensation, it was more likely to be better than worse. And the same thing happened 4 years later when we sent out another 400 questionnaires and we compiled the 100 returns. A 25% return rate's not bad on a questionnaire. So now our informed consent says basically there is no physiological explanation of why sexual responses should be better or worse But if you don't want to take any chance at all that your function could be worse, vasectomy is not for you. So it's really in the informed consent that if they don't want to take any chances that their climax sensation is going to be different or their sex drive is going to be different, maybe this isn't right for you. Now, hopefully that'll stimulate a conversation about why that could be, and maybe those patients just shut it off. But the next paragraph says these are the risks of not having a vasectomy. So we have a separate web page that my daughter helped me compile many years ago on the risks of female contraceptives, including tubal ligation, the risks of pregnancy for unwanted pregnancy, and the risks of childbirth with unwanted pregnancy, all of which are risks unbalanced by any benefit, except for the contraceptive ones. So they have to kind of make a informed decision about whether they're going to take this very, very minor risk that there could be a perceived, again, no physiological explanation, but whether there could be a perceived change in their sexual function. And for me, that has really taken a burden off me. And I'm not using it as an "I told you so" sort of mechanism, but I don't seem to get, and I heard Alex talking to his patient yesterday because he's my associate. We were in the same room. He did a fabulous job going over all of these issues. He was on with the patient for about 40 minutes, I think. So I wouldn't approach a patient any less sympathetically than he did, only it's kind of nice to have that on the informed consent that there could be a change in your sexual function, but if there is, it's likely to be better than worse. That's all it's kind of like that's all I can say, sort of thing. So I don't know if that is something that anybody might want to repeat. You're welcome to use, I can send you a link to that information on our website. You could put that on your website. You could put some references to the literature that's been cited so far in this meeting. But it has taken the burden off me with regard to sexual function. That doesn't mean that I'm any less intrigued by the possibility of that, why that happens, or any less sympathetic, but it helps.
Thank you,
Thank you,
Douglas.
Doug. Hang on just a second. I want to now, we have a little surprise visit from our pareja from El Salvador, and Silvana Resende is going to introduce this couple, and they are going to come live to us and talk about their own sex life
Yeah, I just
after
wanted
vasectomy.
to introduce them.
All
They
right,
are a
Silvana,
couple,
por favor.
Zenet and Dani, a couple from El Salvador, and we were able to meet them last year. Dani is a man that had a vasectomy last year, and they are here because they want to share with us their experience. So, Dani, welcome. Yeah, so for her and for me, it was a great decision because we didn't want to have kids because of our current situation. We don't have the economical power and to have kids. So the economical situation in our country is not good, and the situation is the same in other countries. So we don't have money to have even one child. And also when it comes to health, my partner has some negative symptoms when she uses contraceptives. So we decided that that was the solution because we didn't know how to react to those female contraceptive symptoms that she gets. So my vasectomy procedure was very fast, very quick. John did my vasectomy, and the recovery was great. It was really quick. I didn't have any pain at all after the vasectomy, and ever since, everything has been great. I didn't have any problems at all, no pain, nothing. Yeah, and to tell the truth, we are really happy and really grateful with World Vasectomy Day for the opportunity. and you are great. So you have no idea about the extent that you have helped us, because I have tried a lot of contraceptive methods and everything was awful for me. My health was in a really bad condition because of this, and we decided to have a vasectomy because you gave the opportunity to us to do it. And Silvana, I wanted to thank you because you have helped us a lot. And you taking the time to talk to us and to ask us why we want to have a vasectomy. And that's great because we need to talk about that as a couple with professionals. We have a lot of stress, we have a lot of doubts because this is not really offered in El Salvador, so we don't really talk about this. And we are really grateful, and we really appreciate what Vasectomy did, because for us as a couple, this has been a great gift. So thank you. Thank you, Senet. Thank you, Daniel. Yeah, so as Senet was saying, in El Salvador, we had the chance to meet a lot of people and to talk to a lot of people. We have a lot of discussions in the hospital corridors with young people, with couples, and women like Senet tell us that they are really grateful because they have had a lot of problems with contraceptives, and now their spouse, the man, is in charge and of contraception. So that's great for them. And these moments are really special for them because it changes their lives. And it is also really important for the couple and for the spouse that is waiting for their partner to have a vasectomy, because this is really beautiful. It's a beautiful experience, and we are seeing this in a lot of countries. And I just wanted to say that we go beyond vasectomy. We change a lot of lives, and we gift a great thing to these people. So thank you, Senet. Thank you, Daniela, Daniel, for being here. Yeah, thank you.
Thank you, Silvana. That was wonderful to hear a true couple's story and their experience following vasectomy. I think we have some time for some questions in Spanish. It'd be nice to go out to the whole audience. Deirdre, please tell me otherwise. But we have a couple of questions here from Maria Rene, who's asked a few times. I can't translate the ones that are in Spanish. If anyone wants to jump in and relay those questions for me, but that's from Maria Rene. Maria, if you are available, please feel free to jump in and ask your question, and then we can have the interpreter interpret for us.
Yeah, hi, can you hear me?
Yes, thank you, Maria.
Yeah.
Yes,
okay, great. Yeah, so please give me 2 seconds because I asked a lot of things. Yeah, so one of my questions from the public was if they are going to ejaculate the same amount of semen after the vasectomy. The ejaculation is going to be the same.
I think, Naomi, you're well placed to answer that because that was in your part of your presentation.
Yeah, so sperm itself, which is what we're stopping joining the rest of the ejaculate, is only about 1 to 5% of the total ejaculate. So where we cut the tube, the rest of the ejaculate is produced upstream. So where we're cutting the tube, the only thing that we're removing is the sperm. So when you think about the volume, 95 to 99% of the volume is totally unaffected. So it shouldn't. And I know people do say it has. So a perceived change might happen. But again, there's lots of reasons why that might happen, dehydration, alcohol, other drugs, age. So it's really important that we emphasize it's nothing or very little to do with the vasectomy. It shouldn't be you shouldn't be able to visualize a change in 1 to 5% of your ejaculate.
Thank you, Naomi.
Yeah,
Maria,
just one more.
do you have some more questions for us?
Is there any change in the sensibility of the penis or the scrotum after the vasectomy? Ramiro, you can answer if you want.
Ramiro, puede responder.
Not at all. So, yeah, there's no change of the sensitivity. After the vasectomy, maybe the man can have an epididymitis, and maybe they could feel a change in the sensitivity, but this is not because of the vasectomy, and this is just due to the procedure itself. There's no change in the sensitivity in the penis, and in the scrotum, there's no sensitivity. The sensitivity can have a change in the if the man suffers an epididymitis.
Thank you. We're going to need to close now. I hate to say that because I really feel like this discussion could go on for quite some time. And we have so many questions that were asked that we didn't get answers to. So maybe what we will do is go ahead and see if these questions can be answered at a later date. And if you are signed up for this webinar, we will go ahead and send you some of the answers that we got that we didn't get to today. And in closing, I do want to invite you to, we are in the 24-hour event, we are going to have we're calling it the Doctor's Corner. And we are going to invite all of the medical people that would like to present to submit their ideas to us. And we will try to program this Zoom room so that you can present to each other. And this will be an interesting discussion because you can bring up all these different topics. It's just that we want to program it, so we need to know in advance. So you'll notice in the chat that we're putting up a form. If you're interested in presenting during the 24-hour event, which is November 13th and 14th, it goes all night and all day, we are welcoming you to exchange information with each other because we're not going to have time to do all your questions today. Our translator has to go, and that's part of the reason. But we would really like to continue this discussion as we can. And if you have anything else you want to say, we will stay on for a little while. You can put it in the chat, and then we will try to get back to you as soon as we can look through it and edit it a little bit. Because it's fascinating. Thank you all so much for coming today. This is important. These exchanges of information are beautiful. I love that you all came today, and thank you so much for being here. And thank you so much for our presenters. My gosh, I feel so lucky to have included Rebecca, Naomi, Sarah, Ramiro. Thank you so much for presenting. And of course, Doug, always, we love anything you have to say. All right, everybody go off and have a great day, whatever you're doing next. Ciao.
Thank you, Deidre. Thank you, everyone.